Sub-Tenon anesthesia was first described over 120 years ago when it was used for enucleation of a globe. At that time it was delivered using a needle. Its current level of popularity for cataract surgery has evolved through the use of an atraumatic blunt cannula instead of a needle. This enables direct infiltration of local anesthetic with relative safety into the posterior subtenon space. This technique provides good anesthesia together with akinesia. The materials you need are fairly standard: a pair of conjunctival forceps and Westcott scissors, some anesthetic drops, 5 ml of 2% plain lidocaine, and a 5 ml syringe with a Sub-Tenon's cannula. The cannula has a curved 19-gauge shaft with a smooth, flattened tip which is flared at the end. The curve of the shaft is designed to be slightly less than that of the globe, so that the tip of it doesn't drag over the posterior sclera. First, some local anesthetic drops are given to numb the conjunctiva. Some prefer to insert a speculum at this stage to ensure adequate access. If there's very little lid squeezing, you may prefer to continue without. Next, ask the patient to look upwards and outwards to expose the infranasal quadrant. Make a small cut in the conjunctiva, about 5 mm from the limbus, and then expose the sclera using blunt dissection through the anterior tenon's fascia. Insert the cannula through this opening and gently advance it around the globe following the contour of the sclera. As you do this, you'll meet some resistance from scleral tenon bridging fibers near the equator. Some gentle pressure with hydrodissection will get through these to a point immediately posterior to the equator. Now, slowly inject about 3 ml of anesthetic. You may see some mild proptosis occurring, which is confirmation of the correct site of delivery. This B-mode ultrasound imaging shows dynamically how the fluid distributes over time. To begin with, the solution is being injected on the right-hand side of the globe, behind the equator. You can see clearly a localized separation developing between tenon's fascia and the underlying sclera. 90 seconds later, the solution has diffused across to the temporal side of the globe, outlining the subtenon space on both sides. So now the whole posterior sclera is bathed in a lake of local anesthetic solution. This shows that a single site of delivery to the infranasal quadrant is sufficient to cause wide distribution of local anesthetic solution and accounts for the early profound ocular anesthesia that often occurs after Sub-Tenon delivery. This video has shown you the materials and technique for safely performing posterior Sub-Tenon's local anesthesia. This method produces good anesthesia together with akinesia and offers the advantage of using a blunt cannula. It should therefore be safer than peribulbar or retrobulbar techniques that both use a needle. So overall, it's an effective and safe method of delivery for local anesthesia and is well tolerated by patients who can be reassured that it does not involve the use of needles.